right now. So this week is week 4. So what's due this week is your task, what's due tonight, if you haven't done it yet, task 3, lesson 3, and discussion 3. And of course, for every day that you're late, we chop off a grade. So you got until tonight. I'll check again maybe 10, 11 o'clock tonight to see if anyone submitted, and then I'm going to start doing grades. So please, 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 if you're missing some stuff, get some stuff done. So if you recall your Anatomy and Physiology 1, if you watch this video as well, we talked about the acid-base system. And just a quick review, the definition of the pH and what it is and what it does. So let's look at some, what is the one that I like? So the pH system, here's a nice one. The pH system is essentially, what pH really is the negative log of the concentration of the hydrogen ion. Now, what does that mean in English? Well, there's a system of 1 through 14. Neutral, or where humans should be around 7, 7.4 to be exact. But if you're closer to 1, you're very, very acidic. So if you have like 6 and 5, it's all mildly acidic, right? And then when it gets 3 and 4, it gets significantly acidic. And then when you get 1 or 2, it gets very acidic. And what does acid mean is there's a lot of hydrogen ion, or H+, if you recall your Anatomy and Physiology 1. Now, what's basic? It's the exact opposite. It means that the closer you get to 14, the more basic or alkaline you are, and that is means you have a lot of OH-. Now, either if you're on this side, H+, or on this side, OH-, you know that the minus and the plus, that means it's an ion. That means it's very reactive, highly reactive. So if I put gastric acid on your skin, it will react your skin and it will burn you. Just in the same manner, if I take bleach or ammonia, right, which is pretty basic, and I put that directly on your skin, it would not feel nice. It would there would be some level of chemical burn. Okay, and what's even worse than bleach, around pH 13 or so, is like oven cleaner, which definitely you should not want on your hands or your face or anything remotely sensitive, because it's highly alkaline or highly basic. Now, what does this have to do with what we're talking about this week, which is the kidney? Well, the kidney and the urinary system, they help maintain this balance, because human beings need to be around 7.4, which is around neutral. That means we can't have a lot of H pluses and we can't have a lot of OH minuses. And recall that we're around 66% water, which is, by the way, H2O. If I combine the OH minus and the H plus, that's what? H, 2 H's, and an O. That's water, and that's where we should be. We should be somewhere in the middle. Actually, a normal saline solution should be around 7.3, 7.4 pH, and it should have water and 0.9% sodium chloride. And that's human beings. And that's why we're in the middle. Now, your kidney either throws if you're too basic, it'll throw out a lot of the OH minuses, or if you're too acidic, it'll throw out a lot of the H pluses, and or release buffers that will balance this. And if you recall from Anatomy and Physiology 1, a buffer is either a weak acid or a weak base that will push your pH in the proper direction. So for example, let's say, for example, my patient has a blood pH of 9, okay? The fluids in my patient is too basic. It's too much on this side. So we're going to, your body will, of course, have its own buffers, right? But we can also introduce those same buffers and push you where? Push you towards the middle. So let's say my patient's here at 9. I can give the buffer, maybe you've heard of it, Ringer's lactate, which is lactic acid, which is a mild acid. And what will it do? It will move your pH towards 7.4, or neutral. Now, let's say the exact opposite happens. My patient is very acidotic, which happens a lot with diabetic patients. Let's say they have a pH of 5 or 5.5 around here. That's not very good. So your body and or we introduce into an IV, maybe you've heard of it, sodium bicarb or sodium bicarbonate. Sodium bicarbonate has a lot of OH minuses, and that is a buffer that will slowly move your pH towards the middle. Okay, and this is a big deal when you go to your pathology class for you nurses in the audience. So you watch this and the renal system and how buffers work, and part of that is an extension of what I just went through, which was in your Anatomy and Physiology 1. Now, let's look at the urinary system as a whole and look at all the players in this particular system. So essentially, there are two kidneys, okay? And you have red and blue that's coming off of your azygous vein and descending aorta. And the red, of course, is renal artery. The blue is a renal vein, and it's going into this little part of the kidney called the hilum. So you have two kidneys here. And then from the kidneys, you have a tube, because one of the functions of the kidney, we now already talked about one function, which is pH balance. Another function is the creation of urine. And we're also going to talk about what is urine and what's it made out of in a moment. So the urine then gets formed inside the kidneys and then goes inside this ureter. And then, of course, you have two of them. And then it gets temporarily stored in this little bladder, which is a muscle. And then it goes into this tube, urethra. Now, the reason why you don't wet yourself is because the urethra has a sphincter, which is a band of circular muscle that keeps this tight while the bladder is filling up. But eventually, the bladder will have to be emptied. So you have two kidneys, and you could see here, even though if it's a diagram, you could see that, let's look at a more accurate diagram. Like here, you could see if you're looking at, if this is the right side of my patient, this is the left, you'll see that the right kidney is a little bit lower, and it's a little bit lower because your liver is pretty big, so it pushes it down. Both of these kidneys are located behind the peritoneum or the covering of the abdomen. So they're more towards the back of your patient, and they're behind the peritoneum, hence the term retroperitoneal location. And whoever built us really smart, because these things are very, very important, and they put it in the back where it can be safe. Now, let's go back to that other picture. So I like the simplified picture first. So we have two kidneys, and their function is to make urine, among other functions. We're going to talk about other functions momentarily. And going into the hilum, or in this part, you have a renal artery, you have a renal vein, and you have a ureter. Okay, and the ureter will have urine in it, and then it'll go to the urinary bladder, and then will empty out into the toilet via the urethra, right? And of course, obviously in males, it'll be longer, and in females, it'll be shorter. And that has a clinical significance because your female patient, since the urethra is shorter, it has a greater chance of a urinary tract infection. Okay? So, now that you know all the players in this particular system, let's now focus on the main person, or not person, but the main part, which is the kidney. So what does the kidney do for us? Well, it makes urine. So in order to talk about how urine is made and how it gets transported, let's look at the inside of this kidney. And let's look at the internal structures of the kidney. And when we go to laboratory, I will put the laboratory dates on announcements tonight because it has been confirmed that our laboratory dates have been approved by the university. And if you cannot make the laboratory date that we put out, please give me a call because I'm also having alternative dates and also having Saturday morning laboratories as well for makeups. So let's look at this image of a kidney and how this kidney works. So first, it has blood coming from the descending aorta, goes into this renal artery, and that blood is dirty. And what do we mean by dirty? It has a lot of extra nitrogens, also known as nitrogenous waste. The majority of the things that you need in your body is carbons, hydrogens, and oxygens. You need some nitrogens, but the majority of the other nitrogens we need to get rid of. And we need to get rid of it in the form of ammonia. And the way it does it is, let's say all the nitrogens here are in this renal artery. And let's get a much, much bigger picture. Okay. So it goes in this renal artery. And then you could see that there's two sections in your internal kidney. Here, the outer section is called the cortex or the renal cortex. And this inner section that looks like a whole bunch of funnels, that is your renal medulla. So from this renal artery, the blood goes in here and then it goes to this back level here, which is the filter part of the kidney. And within there, it has this thing called the nephron, which we will go over in a moment. The nephron is the functional unit of the kidney. It does three major functions. It does the filtration, it does the absorption, and it does filtration, reabsorption, and secretion. Now, of course, filtration, it's going to filter out the blood, and anything extra is considered waste. So if I have too much nitrogens, that's extra. We're going to filter that out. If I have too much salt, that's extra. I'm going to filter that out, and that's going to end up in my urine. If I have extra water, that's going to get filtered out, and it's going to end up in my urine. And that's this area here, which is your renal cortex. And then from there, once it makes the urine, you could see here, doesn't this look like a funnel? This is called your renal pyramid. You got to use your imagination a little bit and pretend like this is like a three-dimensional cone or kind of like a funnel. And whoever the histologist was who figured it out said, hey, that looks like a pyramid. And then from this pyramid, do you see this little like indentation here, right? Which is another funnel. And that is your minor calyx. And then it's going to end up into this bigger area here, which will be your major calyx. And then all being funneled down. Sorry if I'm using the word funnel too many times, but that's what essentially the medulla is. It's just a set of funnels. You have your pyramid, you have a minor calyx, major calyx, and all the major calyces end up in the renal pelvis. And then from the renal pelvis, it goes down into your ureter. Now, how does the urine doesn't just fall down? It also goes down via peristalsis because the, what do you call that? The ureter is lined with circular muscle, and just like in the same way you swallow, it kind of coaxes and in waves pushes the urine down into the temporary storage, which is your urinary bladder. So again, to review, you have your renal.
Not like that. You look just
here.
Like
You have a question? Hold up, I got to get back the picture. Right? So this is your renal cortex, and that's where the filtering, the reabsorption, and the secretion happen. And we'll talk about reabsorption and secretion in a moment when we talk about the nephron. The nephron are all these microscopic things all in here. And then it goes, then the urine, once it gets formed, goes through a series of funnels, starting with your renal pyramid, then your minor calyx, then into your major calyces, which is here, this like lighter color area, and then all coming together with your renal pelvis into your ureter. Okay. Now this area right here, where the renal artery and the renal vein and the ureter meet, is called your hilum, H-I-L-U-M. And that's a classic anatomy question. What are the structures in the hilum? You'll say renal artery, renal vein, and your ureter. Now, once all that blood, right, from the red, right, once it goes into all the capillaries here in your cortex, all the blood gets filtered out of all the excess things that your body doesn't want, and then all the clean blood then goes back into the system into your renal vein. Now, in real life, all of this is called, if you look at a real kidney, it's like 18 shades of brown, and the arteries and veins as well. But in lab, we'll show you how to differentiate. But for your textbook, the red is colored for artery, the blue for veins. Okay, and those are the internal structures of your kidney, which is the star of your urinary tract. And if you look at your urinary tract, if you look at this, and this is your adrenal glands, is extra, right? You can have problems here, here, and here. You can have problems in your ureter, like if you have a UTI, a urinary tract infection. You could have cystitis, a bladder problem. You can have urethritis, right, which is a urethra problem. It's all well and good, but if you have a kidney problem, that is a serious, serious thing. So when you have a chronic UTI, I want to deal with it when it's down here. When it goes all the way up here, that's when we're getting into a lot of big trouble, and that's when we have to call the nephrologist, and that's never fun. Okay? So now let's look at the nephron, because remember I told you a minute ago that the cortex was full of these microscopic structures. And here's a pretty picture. Look at this picture. And there. This thing I want to look at. Okay. So what is the nephron? All of these little tubes are located in your cortex of your kidney, and there's a couple 100 million of them, and they're all microscopic, and they start off with, you know, your artery, and then it gets really, really small into arterial, and then it ends up here, which is this is called your glomerulus. Your glomerulus is the location of filtration in your kidneys. And that's when it takes all the, for lack of a better term, dirty blood, or the blood with all the extra garbage in it, right? Because remember, anything that's extra, your body doesn't want, it's garbage to your body. So it tries to get rid of it, okay? Because too much of a good thing becomes a bad thing. So we have here the glomerulus, which is a tuft, or like a kind of like a ball, like a dust bunny-like ball of capillaries. And in those capillaries, right, gets surrounded by the structure around there called the Bowman's capsule. Now, this is where filtration takes place. Everything gets filtered out, and then the blood then goes through a venule, which is this really small vein, and then will eventually end up in the venous system. And in theory, it's supposed to be clean. But filtration isn't 100%. Sometimes things that we were supposed to throw out stay inside the blood, and that's not good. right? And also sometimes things that we um, that we wanted to keep, right, get accidentally thrown out. So that's where the two extra systems come into play. So you have filtration here, and there's two other systems just in case this filtration system here isn't 100%. And that's called reabsorption and secretion. So secretion happens further down the line, and secretion is when something that you were supposed to throw out, they forgot, the filtration system forgot to throw out. So then your kidney will then secrete it. And reabsorption is, let's say, for example, you threw out glucose or sugar, but your kidney goes, wait a minute, I need some more extra sugar. And that's called reabsorption. So you have two backup systems other than filtration. You have filtration, reabsorption, just in case we threw out something that we wanted, and secretion, just in case we forgot to throw something out, but then remembered, oh no, that's garbage anyway, so I have to throw that out. And that all happens in these extra tubes here. You have, after your tuft of capillaries, you have a proximal convoluted tubule, and this green thing here, a distal convoluted tubule, and in between, you have your loop of Henle. Just know for right now, the loop of Henle is where the salt and water get reabsorbed and or secreted. And that's the main function of this loop of Henle. So you have a proximal convoluted tubule, a loop of Henle, a distal convoluted tubule, and then you have a collecting duct, and then the collecting duct ends up in the renal pyramids. Just imagine a whole bunch of those collecting ducts all ending up in the renal pyramids and all ending up in those funnels. So you could see where it starts off as blood and then it gets filtered, goes through all these tubes, salt and water get filtered out here, and then it ends up in this distal convoluted tubule, then into this tube and goes down here. This should amaze you because all right now, this is all happening as long as your heart beats. You will always have urine. I always tell the story of when I was 5 years old. Um, I remember my cousin being very upset at me because I would go to the bathroom, I'd urinate, and then I'd walk around the apartment, and then I'd go urinate again a minute later, and then I'd do it again like every 2 minutes because I was always amazed. Like no matter what I did, whether I drank or not, I'm always urinating. I was, as you could see, I was a very strange child. But but it was nice to learn in graduate school. This is the reason why, because as long as there's blood that needs to be filtered, and your body needs to either keep things, right, reabsorption, or it needs to throw out things, secretion. And the filtration happens here in this thing called the glomerulus that's surrounded by your Bowman's capsule. So now you know if your patient has glomerulonephritis, this thing isn't working. That means this is a very, very serious kidney disease, right? And if now you may know, you might hear the word loop diuretic, and you know diuretic is a water pill, and it helps reduce your blood pressure because the loop diuretic tells the loop of Henle, hey, throw out water, throw out salt. And if you recall your Anatomy and Physiology 1, if my body starts throwing out salt, what will follow? Water, right? And that's because of osmosis and diffusion. And if you don't know why, please look back on your Anatomy and Physiology 1 or give me a call and I'll do a little quick video for you. Okay? So that is the nephron. This whole entire thing. And again, as a review, what are the parts of the nephron? You have your glomerulus, surrounding the glomerulus, your Bowman's capsule. Then it goes through a proximal convoluted tubule, then the loop of Henle, then the distal convoluted tubule, and then into a collecting duct, which is here, or collecting tubule, as this particular diagram states. Okay? And duct, tubule, same difference. And that's the and there's millions of them, and you have 2 kidneys, you can survive with one, but you're going to need dialysis if you only have one. And if you only have one, it gets taxed. It gets very hard to use because your body requires 2 of them. So did we go over a little bit of what urine is made out of? Yes. Urine is made out of anything that's a waste product of our metabolism or of our body. So whatever you have too much of, it will end up in your urine. Now, in theory, you're not supposed to have glucose in your urine, but you eat a ton of sugar, or if you're diabetic, what will end up in your urine? Glucose. You shouldn't have blood in your urine unless it's you're female and you're going through your menstrual cycle, but blood is really important and should not be filtered out. So a general rule of thumb, what should you be in urine? Essentially water or any waste products. We then talked about the structure of urine transport, how it goes through, and what does the kidney look like in both macroscopic, large, and also microscopic, which is the nephron. So right there, and you'll go in your clinical classes much further regarding the properties of urine. Urine is slightly acidic. It shouldn't be any more than like 6.5, 6.4. It's just slightly acidic, so it's not like if you urinate on something, it shouldn't burn anything. And by the way, your urine is considered sterile when it leaves. But remember, you put any water, you just lay it around, bacteria will grow. And that's the reason why whoever took care of you always told you, don't hold in your urine. And also you shouldn't hold it because you could get a spasm, it could hurt. Also, your bladder is only a temporary holding station. It will eventually push and you will eventually urinate. Now, if you look at this physiology lab, please do not do the physiology lab, but it has some really nice notes, and you could see how it's like word forms of the lecture that I just went over. There's nice little notes up here. Okay, and get a little bit of 3 main components of urine, which is your physical characteristics, microscopic and chemical analysis. But anatomy and physiology doesn't focus on that. On your clinical classes, they'll be focusing on this a little bit more. So urinary system structure, kidney, endocrine. Now, let's talk about the endocrine regulation of the kidney function. Now, all well and good this video, which I kind of don't like, but let's look at this diagram, which is the RAA system. And you can see there's a nice video, but I'm going to show you and how your endocrine system and your urinary system. Remember, I stated in previous lectures that all these systems, even though we talk about it in different chapters, they're all related and they all connect. And one of those systems is this right here, which is the RAA, or renin angiotensin aldosterone system. And if you recall the last chapter of your Anatomy and Physiology 1, we talked about, you have some sort of stimulus, right? Which was the, why am I just saying it? Let me just show you it. Everything that we're talking about in all the anatomy and physiology class and your pathology classes, we're talking about this thing right here. Everything that your body is doing is to maintain some sort of status quo, to maintain homeostasis. You look at the word homeostasis, stasis means to stand still, homeo means sane. So just like a thermostat, you want to stay where? In the middle. Too much of a good thing becomes disease or pathology. Too little of a good thing becomes disease or pathology. Now, before we start looking at the RAA system, I'm just going to review really quick on how your body monitors itself. You have ascending fibers or sensory fibers, also known as your afferent pathway, and they have receptors. Your body detects changes. And then the control center, of course, is always your brain. And then it's going to send a message to effect change through the efferent pathway, also known as your effector pathway. So it's going to effect a change. So right now, like the way your urine is being formed, there's sensors figuring out, oh, what's in the urine? Then it gives a message to the control center of your brain. And then the effector will then tell the bladder to go push, your sphincters to relax so you can urinate. And all of this happens without you really thinking about it. So knowing that and understanding that, let's look at this. Now, when you're looking at something like this, and this is also the reason why we're training you guys to do those concept maps, because you could see if you watch that video, I don't know about you, the video kind of confused me a little. So that's why I don't like looking at it too much. But I like when there are nice pathways that I clearly can see. And can everyone see that you can already see the three parts, right? Of first you have to have something that stimulates it, and then you have the process, and then you have its effects. Can everyone see that there's almost like three parts? And that's called chunking. That technique of looking at something that's like complex like this is a way that you can put like ideas together, so you're not memorizing things all in little steps. Because if you memorized all of this in steps, there's 16 steps with all these arrows. It's very, very confusing. But now that I know that there has to be some sort of stimulus, there has to be some sort of process, and there has to be some sort of effector or thing that will change so that I will maintain homeostasis. So now I can memorize this thing in 3 or 4 steps. And you could see here, and also you could watch a video and listen to a video all day, but I like drawing things out. And one way you could do it is you could try this and on a scrap piece of paper, draw this out yourself, or draw this out in parts, just like you would do your concept map. And then by that, you constantly do that, and repetition breeds memory. So let's look at the first 3 parts. Now, how does the kidneys control blood pressure? Well, something's got to spark it, right? So what happens is, how does your body know you have a decrease in blood pressure? Well, decrease in blood pressure is the same thing as a decrease in volume. It's just like, in summertime, you're messing around with a hose in your backyard. What happens if, your friend, you know, on purpose starts lowering or shutting off the water? The hose gets less tight, and then the water flow gets less and less, right? So wouldn't that be a decrease in volume, hence a decrease in blood pressure? Now, what could cause that? And remember I told you wherever salt goes, water goes? If I took salt out of a human being, what will happen? The water will also go out. And isn't that what happens when you sweat or when you work out? When you work out, your sweat has a lot of salts, and then it goes, you start sweating, and then the salt starts leaching out of your skin, and so does the water. Or if I bled too much, hemorrhage. That's another way that I can decrease my blood volume. So all of this together, you learn it like a story. So I think about situations that can decrease my blood volume, hence decrease my blood pressure. So if I shot somebody, of course, blood will leak on the floor. They'll have a decrease in blood pressure. If I made somebody sweat to the point where all the salt got taken out of them, or it goes, I put my patient in in one of those sauna baths. And if ever you've been in one, do not stay stay in one more than 20 to 25 minutes, and make sure you're constantly hydrating yourself when you're in a sauna, because you will get dehydrated. So this little story here, that is our sensory. Our body senses sodium, it senses water, it senses blood. And one of the biggest sensors in your body regarding blood and fluid is, of course, your kidneys. So what has to happen? So right now, my patient's blood pressure is in the basement, so it's going to signal a whole bunch of things. So the JG cells are your juxtaglomerular cells of your kidneys, right? Juxta means right next to. So right next to your glomerulus, there's these cells that will do what? They will send out this hormone called renin, and all hormones are they're just chemical messengers. So all of these are just chemical messengers, and if you see it as that, then and we now know the problem is low blood pressure. So the JG cells will send out renin, and what will renin do? Angiotensinogen from your liver is an inactive hormone, but once it meets renin, it becomes activated to angiotensin 1. Then angiotensin 1 gets activated to angiotensin 2, and it gets activated through an angiotensin converting enzyme, which is in your lungs. Now, that's one whole big story. So it starts again here. JG cells of my kidneys, renin, then my liver secretes angiotensinogen. And how do I know angiotensinogen is an inactive hormone? Look at the word gen, creation of, right? So it goes then to angiotensin 1, which then gets converted by ACE, angiotensin 2. And then what happens? What we want. And what do we want? Remember, our sensory was telling us we have low blood volume, low blood pressure. So what will happen when all of these things come into play? There'll be vasoconstriction of my arterioles. That means someone's going to start squeezing on the arteries, and that will increase my blood pressure. What will also happen? There'll be increased aldosterone from my adrenal cortex. And what will that do? It will now tell all the kidneys to keep all the sodium. And remember what I said? Wherever sodium goes, water goes. So that will also increase blood volume. So now when you look at this, you can actually see how we attack high blood pressure. Because what makes high blood pressure? This system. So if I can shut down this system, can I get low blood pressure, right? Here's one way. Maybe some of you are taking an ACE inhibitor, right? Or maybe your family's taking an ACE inhibitor, right? So if I inhibit this, will we get to this? Nope. So my blood pressure will remain low. Remember we talked about those diuretics? What happened if I tell these diuretics, right? Oh, don't keep the sodium, throw it out. And what will happen? I'll have decreased blood volume, and then my blood pressure will go back up. And here you see potassium, right? Increase of potassium. We also have potassium sparing diuretics that do the same thing. So you could see now what kind of questions could come out on exams. They could ask you, what is the function of RAA, or the renin angiotensin aldosterone system? We already know the endpoint. I want to increase my blood pressure. How does it do it? Well, there's two ways. Blood volume, which is here, and vasoconstriction of arterioles. Oh, how does it do the vasoconstriction of arterioles? You have this story right here, right? Oh, how does it increase the blood volume? And you have this story out here, your adrenal cortex, and then it tells the kidneys to do what? Reabsorb or keep sodium. And remember, wherever sodium goes, water goes. So this is RAA, and this is a classic. You will be always asked questions regarding this, especially all of you future nurses. They love asking this with respect to pharmacology, and you're going to learn other drugs that mess with this. But one of the more famous ones is an ACE inhibitor right here, which, by the way, You can remember it by this picture in the lungs. Most common side effect for someone on ACE inhibitors, chronic cough, because that's where ACE or angiotensin converting enzyme lives. And you can even look at the word angiotensin. Angio means blood vessel. Tensin means what? To tense or to press. So it's obviously going to press on your blood vessels and then make your blood pressure increase in response to the original stimulus of low blood pressure. So all this happens, right? When you have dehydration, sodium deficiency, and or hemorrhage, all of this, it sets off a chain of events, so that will go here. Now, it also has a negative feedback loop. So once a good blood pressure is maintained, the negative feedback loop then tells all these other players, hey, slow it down. We have enough blood pressure. Okay? So that is the RAA system. And you could pause the video and then copy and paste, or you can even Google it like I did, and it's the one that has this picture. I find this one was the easiest one, and it's better than this video because this video starts talking about chemistry and stuff like that, and I believe it's a little bit, it waters down the overall message. So that is an example of endocrine regulation of your kidney function. And you could see how we talked about this particular lecture in 3 parts. You can easily make a concept map in 3 parts, all right? Structure and function, urinary system as a whole, kidney, just as the star of the show, right? And endocrine, you could talk about RAA, okay? And please don't just copy and paste, because I know you can find Google a concept map. Actually try it and do it on your own, because again, in the near future, there will be very, very complex things that won't have a concept map, or there are specific protocols to a specific ward. And having this skill set of making a concept map is a pretty handy thing to have. So of course, that's due next week. Please try to put it in some sort of either JPEG or a Microsoft Word, or something that's like a file, because if you just copy and paste it onto your your submission, it kind of blurs everybody else's stuff and it's hard to read. So, and if you're confused about how to submit, if I didn't make a comment to you, you should be fine. But if I have comments, please look at the comments, and if you're still confused about the comments, please send me a message. Now, discussion 4. Good on you, Ms. Taylor. Already has a, and I already replied. African Americans, Hispanics, American Indians, people from Bangladesh, they have chronic kidney disease. So research on why is this, right? What are the and what are the effects? So there's 2 things. Now, at least 200 words, and make sure it's an APA format, because again, it's the university's format and most of academia's format. And again, you could say all you want, oh, they have higher kidney disease because of their food. Okay, then I need data. I need somebody with a .gov, .edu, to back you up. And some of you are already replying to others. If you want to reply to somebody else's post, it goes, get into the practice of not only saying, hey, that's a great post, you're awesome, that's not academia. You go in and you reply. Let's say I disagreed with you. Goes, no, I disagree with this statement. People in Sri Lanka and Pakistan don't have chronic kidney disease, and here's my data on why, right? Try to find something that's relevant and new within the last 5 years. And of course, if you still have problems with APA, please give me a call. And of course, that's due next week. That's your discussion 4. Now let's look at the lesson 4. Now, I had 1 or 2 people tell me, like, I can't open up the lesson, and it's not, and again, here's another urinary physiology lab. Again, do not do the lab. We'll be doing dissection on this, and there's really nice notes in there. This is the thing that we're always doing, the case studies. You click on the case study, and of course, click download the case. and it should be in a PDF file, PDF type of file. And this was back in about 10 years ago, but this is a case where this girl was pulled out alive 2 weeks. So how could she survive 2 weeks with no food, no water? So read, and from the lecture that you had now, you could start pretty much starting to figure out why and how she survived. So what I want submitted is part 1, questions 1 and 2, part 2, questions 3, 4, 5, 6, 7. Oh no, 3, 4, 5, 6. Do not do 7. Okay, because that's a little out of hand. That's when we start doing some math. But you'll do that for you future nurses. You'll be calculating all that stuff later. So remember, part 1, those 1 or 2 questions. Part 2, questions 3, 4, 5, and 6. Do not do the calculation of Darlene's water loss. You will be doing that in your pathology class when you're in when you're in that class, pathology. And so don't do the calculation questions, but you can also do part 3, questions 8 and 9. So do not do question 7 in part 2, but do all the other parts. And you don't need much. You can, our lecture and the items in within these paragraphs should be enough for you to answer. Or, hey, Google it. That's what it's there for. But remember, make sure it's from a legitimate source. All right, that's all I have for this week. Does anyone have any questions regarding what we did today? Let me grab 4. And if not, thank you very much. And I'll see you next week or during the week. And remember to look out for announcements for the lab days, and get to me real soon, especially if you cannot make those lab days. Okay? All right, everyone. Have a good one. And I don't know what else to say. Stay safe and have a good one. Bye.
Thank you.
Thank you.
Thank you.